the apex is in the lumbar spine, and that depends on your characteristics of your spine. So they concluded that they thought PJK might be caused by a postoperative posterior imbalance due to increased lumbar lordosis, an inadequate thoracic kyphosis, or that you'd actually shifted the apex of the lumbar spine during the surgery. The next paper was the European Spine Study Group, and they looked at the ideal sagittal profile restoration, so looking to see where they should put you back to, and the lumbar apex positioning after pedicle subtraction osteotomy. Now, PSOs are a complex procedure on their own, and trying to take out or create the correct osteotomy to recreate the correct lordosis is a challenge, because when you're doing the correction, you have to stop when you start getting wrinkling of the dural sac. Otherwise, you run the risk of significant neurological compromise. So sometimes you may not correct as much as you hoped and as much as your bony resections will allow. They looked at 87 patients, of whom 40% suffered a mechanical complication of some sort. 7 PJKs, 4 PJFs, and 18 pseudarthroses or rod breakages, and 6 screw pullouts. So they had nearly half actually had major complications. And what they showed primarily was that if your apex was in the wrong place and you'd mismatched the lumbar lordosis, you stood a significant chance of running into mechanical complications after PSO. The European Study Group also looked at this with respect to the Wosely sagittal profile, and what they showed was that if you had a higher postoperative global tilt and pelvic tilt, and your upper instrumented vertebra was increased, if you'd gone to the ilium, and if you had a Wosely mismatch, you stood a massively increased chance of mechanical complications. They found 72% failure rate in the mismatched group versus 15% in the matched group. So their recommendation was to restore to the ideal Wosely profile to reduce the rate of complications. And they mentioned specifically patients older than 65, because as you get older, you tend to have a bit more of an increased pelvic tilt and thoracic kyphosis, and your SVA will increase. So you don't actually correct to perfect, you correct to maybe match perfect, what they call ideal. The next group is the ISSG with very famous names, Lafarge, Swab, Chris Shaffrey, etc. And they were looking at their data as well. And I'll talk more about this a bit later on, but they compared proximal implants with screws or hooks, compared with using other things like cement, overcorrection, undercorrection, or getting the alignment correct. And what they showed primarily was if you overcorrected, you hadn't made any preventative measures to try and prevent a PJK, then your rate of proximal junctional failure was 25%. If you got it aligned correctly, you had some preventative implants at the proximal end, your rate was reduced to 10%. That is still 10%, unfortunately. These are the Wosely different types of spine. So he initially characterized these into 4 types. He has subclassified into a 5th now as well, but I'm not going to talk about that today. The type 1, the inflection point is quite low down here. So you have quite a long thoracic kyphosis and a very small lumbar lordosis. It's almost kyphotic, really. Whereas if you look at the types 2, 3, and 4, you get progressively your apex goes higher. So the apex in the type 1 is at L3-4. In the type 2, it's at L1-2. By the time you get up to type 3, it's T12-L1, the thoracolumbar junction. And the type 4s is up in the thorax at T9, T10. This is most relevant for trying to avoid proximal junctional kyphosis and stopping at T10, because you are stopping well, you're very close to the apex of the curve. It's a little bit higher, but in some cases you'll still be in the kyphosis here, but you should be going into lordosis, and the rods should match that. This just demonstrates the increasing pelvic tilt as you age with an increasing thoracic kyphosis. And the idea of this is that you still keep your C7 plumb line over the sacrum to try and maintain your SVA in a fairly neutral position. If you don't have this pelvic tilt and your cranium is over here somewhere, you'll find that the energy expenditure is very high and you'll fatigue and you get a lot of mechanical back pains. This paper showed a mismatch between the proximal rod contouring and proximal junctional angle as a risk factor for PJK due to rod pullout. And you can see on this picture here that this doesn't look too bad, but the spine is going off into more kyphosis, and these rods should be more contoured to try and avoid any pullout. But the temptation with doing this surgery is you're trying to correct as much as you can, and you leave a little bit of lordosis or not enough kyphosis onto these rods, hoping to pull the spine to you. Unfortunately, that's what increases the pullout. And you can see these are screws which have got different pitches on them to try and make sure that they have a good hold in the spine. And these have used cement in the levels further down, so they're obviously concerned about osteoporosis in the first place. Another topic which doesn't get very much attention is prior neurological deficit before you do any surgery, increasing the rates of PJK. And this group demonstrated quite nicely that if you have neurological deficits, you have a 75% chance, or your chances were 75% higher, 75% versus 32, that you would develop PJK. And their neurological deficits included CVA, metabolic encephalopathies, Parkinson's, seizure disorders, cervical and thoracic myelopathy, diabetes, and other neuropathies. The cervical and thoracic myelopathy is one of the main reasons we do the surgery, so this is one that we'll find difficult to escape from. And diabetic neuropathies are much more common than we realise, as we don't often look for them. And many of our patients will be older, they'll be higher body mass index, and they're likely to be type 2 diabetics. The next risk factor is using bicortical screw fixation in the upper instrumented vertebra. And this was very nicely demonstrated by a group, I think, from South Korea. And they had 3 different groups in their research. They had a group where they put normal, simple unicortical screws, a group with bicortical screws and cement augmentation, and then a third group with bicortical screws without any cement augmentation. And they showed very significantly that if you just have unicortical screws, they had 0% UIV failure, a fracture. If you have bicortical screws and no cement, a 42.9% rate of failure. And if you put cement in with bicortical screws, it only reduced to 31.3, so significantly higher than simple unicortical screws. So their advice was very strongly that you mustn't put bicortical screws into the UIV. Regardless of whether you use an orthosis, it still has a very high rate of failure. Other risks are using an anatomic trajectory for the pedicle screws at the UIV. Now, anatomic trajectory is following the line of the pedicle, which, as you go further up in the thoracic spine, tends to angle a lot more down. And anyone who's done pedicle screws in the upper thoracic vertebra will know that you quite often have to actually remove the inferior facet from the vertebra above and remove the facet capsule to actually start the pedicle screws, which are higher than the body and then angled down quite significantly. And if you follow the line of the pedicle, that's an anatomic trajectory. What is recommended very much is that you follow what's called the straight ahead screw, or straightforward screw, where you start a little bit more inferiorly and try and follow the line of the superior end plate. as that tends to buttress the end plate much better than if your screw is heading down towards the antero-inferior corner, which has no buttressing effect for the superior end plate and is much more prone to failure. And they showed this with an odds ratio of 7.59, so significant risk. Other risk factors, the flexibility of a thoracic kyphosis, whether it's a flexed or a rigid thoracic kyphosis, makes a significant difference. And you can tell this by doing plain X-ray lateral in standing and supine imaging. And a flexible thoracic curve is defined as a 10-degree difference between standing and lying supine. And what this group showed was that if you had more than 10 degrees of thoracic kyphosis, there was no proximal junctional kyphosis. Whereas if you had a reduced flexibility, so less than 10% of 10 degrees, and your angle of PJK was increased at follow-up significantly. So, and they found PJK in 14% compared to 0. So one of the recommendations they made was to do standing and supine imaging to look for the flexibility of the thoracic kyphosis. So we'll look at some preventative strategies. We've talked about posterior tethers in the finite element analysis, and Frank Schwab and Chris Chaffee have looked at this, and they used a model with 6 different implants. Started off with just pedicle screws from T11 to L5, and then gradually added transverse process hooks at T11, so the UIV to start with. And then they started adding tethers to the spinous processes from UIV +1, and then to UIV +2, and finally to UIV +3. So they went 3 levels above the end of the implants. And what they showed was that reduced the intradiscal pressure significantly, the loads on the pedicle screws, and the ligament forces in the posterior ligament complex all reduced with the increasing numbers of tethers that you used. And the next paper showed alignment factors. And what they were looking at was the amount of lordosis in the upper lumbar spine, which is more the type 4 Wosely. And notice that they use a PJK of 10 degrees. So they're one of the smaller ones as opposed to the 20s. But they found that if you had an upper lumbar lordosis, you had a higher risk of PJK, but the tether was protective against it. And the PJK with the tethers was more common if you had a post-operative lumbar lordosis in the upper lumbar spine, and if your UAE angle was also more lordotic. So other preventative strategies, semi-rigid fixation in constructs. This group used 3 different types of semi-rigid fixation constructs, and then measured the intradiscal pressures and the proximal junction motion. And this was a cadaveric study. And they used pedicle screws T10 to L2, had a control which was negative, and then different hybrid fixations with either merceline tape or sublaminar bands for 1 or 2 levels. And all of the constructs did reduce the change in intradiscal pressure in the upper instrumented vertebra +1, in flexion and also in torsion. And if you had 2 levels above, that reduced the pressures for the intradiscal in extension as well. So what they recommended was this created a transition zone, what we call a topping off type procedure, to try and reduce the stresses at the proximal junctional level. Strap stabilization was also used in another group. This was only a fairly small, they had 20 cases with 60 controls. But they did show that PJK rate was reduced. It was 15% in the cases where they've been used versus 38% of controls. The other bits of it were not so relevant, but age more than 55 years old increased your risk. the number of levels fused being greater if you had a thoracic UIV, or if your BMI was over 27, and obviously osteoporosis, quite significant risk, odds ratio of 0.13. So they suggested that using the upper instrumented vertebra +1 would reduce the risks for PJK. Finite element analysis by Chris Shafi and Schwab and Lafarge showed that they tethered, I'm trying to remember what they did +1 and +2, and then different types of loop fixation or weaves. So they just did a number of different types of fixation. And they found that the most useful ones were the weave tethers, reduce the adjacent segment stresses in the long constructs. The important point was there's an inflection point at about 100 newtons, and if you tightened more than that, you started to increase the junctional range of motion and intradiscal pressures. So you have to be very careful to avoid over-tightening the tethers. Unfortunately, this next paper shows that polyester tethers actually stretch quite a lot when you load them in physiological ranges. And so it becomes very difficult to know how much pre-tension you should put on these to try and prevent PJK without actually increasing the load so that it goes over the levels and increases the risk of you developing the PJK you're trying to prevent. So it does make it rather more complicated. This was the paper we looked at before, and what the ISSG did here, which was only published a couple of months ago, was looked at 625 people, and they looked at the incidence of PJF, comparing it with implants at the upper instrumented vertebral level versus nothing. And the levels, they used either TP hooks or nothing, and looking at the sagittal alignment, the SVA. And so what they said was that if you align correctly and you use TP hooks, you can reduce the rates of PJF to around 9.9%. Whereas if you overcorrect, the SVA is not correct, and there's no prophylaxis at the upper instrumented level or +1, then you have a nearly 25% chance of developing PJK and PJF. And so the other question, should you avoid the thoracolumbar junction, so between T10 and L1 as the UIE level? And what this group showed was that, yes, if you're more than 70 years old, you have osteoporosis, or your proximal junctional angle is greater than 0, you had a higher risk for proximal junctional failure, and therefore you should not stop at the thoracolumbar junction. You should go proximally up to T1, T2 level, which is a lot more surgery, but if it prevents PJK or PJF, it'll save you going back 2, 3, 4, 5 times. So the question of whether to do prophylactic cement vertebroplasty at the upper instrumented levels, and this is Khalid Kabesh who did this in the US, and he looked at 41 patients with a 5-year follow-up, and of his patients, 28.2% developed PJKs and 5% PJFs. Only two of the PJKs required revising, but there were no proximal junction fractures. So what he showed was that the vertebroplasty may minimize the risk of junctional failure, but it doesn't reduce the risk of the PJK. So as you'd expect, with bone cement being good in compression, it resisted fracture, but it doesn't stop translation or angulation. This other paper, pedicle screws versus TP hooks, what they showed was that using TP hooks at the upper instrumented level actually prevented vertebral collapse. It didn't stop the risk of developing the PJK, but it did reduce the risk of actually fracturing the vertebra itself. And they had a few pictures. So this shows a lady who's had initial surgery with pedicle screws at the top, and she's developing more of a collapse at this level. I compared with the TP hooks at the top level, and there's no fracture in this vertebra. I know it's not coming out too well on the screen, so I apologise for that. So their recommendation was to use the hooks to try and reduce the fractures, but that they needed to do more biomechanical studies to work out why this was. Was it reducing the mechanical load when you use the hooks, which I think the finite element analysis showed better. There's another measurement recently been published last month, which shows a C2 plumb line to try and predict proximal junction kyphosis. And in this case, what they were doing was looking at perioperative sitting X-rays. And they looked at all of the different alignments, so the cervical lordosis, SVA, T1 slopes, thoracic kyphosis, lumbar lordosis, PI, PT, sacral slope, and the level of the kyphotic index. They used a 20-degree angle for their proximal junctional failure. And out of the 113 patients, they had 10 developed post-operative PJK and 3 revised due to PJF with neurological deficit. And when they compared the standing and sitting profiles, they found that the cervical lordosis, thoracic kyphosis, and pelvic tilt became larger. The SVA became frontal, so the patient kyphosed. Lumbar lordosis and sacral slope became smaller, and the kyphosis angle became caudal. And they showed that with logistic regression analysis, that the plumb line for the C2 was the most predictable thing, and they predicted a cutoff value of 115 millimeters of the C2 plumb line for predicting PJK, and suggest that this might be something that you could use to predict an impending PJK preoperatively. So my treatment strategies: if you can do something less than correct the whole thing, if you can just do a limited decompression infusion, that might be a decent first step. Your distal and proximal fusion levels should be neutral vertebra, and they should be stable. You want your patient prone on an adjustable table with the hips extended, so that you give them the maximum lumbar lordosis that you can without doing any surgical correction. The abdomen needs to hang free to reduce bleeding, and also on this adjustable table, you'll be able to get the thoracic kyphosis into position as well. You can stop your construct at L5 instead of going into the sacrum or ilium or pelvis if you have good enough bone quality, you have a fractional curve of less than 15 degrees, and a relatively healthy L5S1 level. Unfortunately, this is not very common. Your proximal level should never be at the thoracic apex, T5 to T8. You're such a high risk of pulling out. If you have a high thoracic UIV, or you need to use that if there's any osteoporosis, or if their age is more than 70 anyway. Try and correct the SVA appropriate to age and get the ideal apex lumbar position correct. And this is what you work out preoperatively using computer software, or there are apps that you can do it as well. Try and correct your pelvic instruments and lumbar lordosis mismatch accurately, and taking significant care if your lumbar lordosis correction is more than 30 degrees, as this is such a strong risk to PJK. And preoperatively correct your osteoporosis if you physically can. You can either use teriparatidal denosumab for high-risk patients, or the guidance says alendronate for moderate risk. I must admit, I'm not a fan of bisphosphonates, as they don't actually increase bone density, or not with useful bone, they're just not bone breakdown. And if a patient is osteoporotic and you have no choice but to operate, you need to have as many fixation points as you can. Try and use hydroxyapatite coated screws, cement augment your screws. An argument about anterior column support, and the literature doesn't have any good basis for arguing for and against this. In years gone by, it was argued that anterior column support increased the risk of PJK, but lately it's with more MIS surgery, it's unknown. You need to try and limit the dissection superiorly. When you go into the thoracic spine, as I was saying earlier, to put pedicle screws in, you're inevitably going to be damaging the facet joints for the vertebra above, as your entry point is straight through the facet. Doing minimally invasive surgery for this reduces how much of the facet capsule you'll remove, but it doesn't remove it entirely. But you will not strip off the muscles so much. And consider topping off your construct with hooks, polyester tapes, at certainly UIE +1 and +2, and you could consider +3 based on some of the studies. And injecting cement into UIV at +1 and +2 is a possibility as well. A couple of little salvage options. If you get a PJF in someone who's not very fit for surgery, this is from the US. This group had a patient who developed this PJK and PJF, and they got an interventional radiologist to do a percutaneous trocar and then use a curette and a burr to actually try and make a hole straight through the UIV, UIE +1 +2, to try and make a continuous column of bone cement, which is also what my friend Sean did in the UK with a lady who wasn't fit for revision surgery but with significant problems. This was the picture I showed to start with. You see she's got a PJK of 66 degrees. PJA. SPECT scan showed that this was the main source of her pain, and so he's stuck a trocar into the UIE +1, one to the +2 in the normal spot, and then another trocar to go through the end plate and into the disc and into this vertebra to try and create a constant column. And he managed, by lying her on the table with some lordosis, to actually reduce her proximal junctional angle to 43 degrees, and the pain was relieved by loss of micromotion at the fracture site. This is the second case we're going to show, which is a patient who had had this done in a separate hospital previously, so L5 for nothing into 3 and then 2 in 1, and you can see that she's developed a kyphosis, and also this is now at the apex on the coronal balance, which is a bad prognostic sign for progression. And so she underwent revision. Oh, this is the CT scans, which shows significant lucency around the proximal level, suggesting that there's not been any union and failure, but there was no infection. But there's been a non-union through the proximal levels. So she was revised up to T10. Generally, you'd say that didn't look too bad. This is post-op day 1, and unfortunately, by 6 weeks, she'd started to develop a further junctional kyphosis with a proximal junction angle had risen to 37 with the end plate failure of the upper instrumented vertebra. And by 9 months, it had progressed to 53 degrees. And this is quite common with these patients who are osteoporotic and often not in the best health. So she was revised to go up to T2 and with end-to-end connectors, and also had a double rod construct, so 4 rods around the level. End-to-end connectors are notoriously unreliable and weak. And this generally didn't look too bad. Unfortunately, she came back again with a further level up at the top and another junctional failure with spinal stenosis at that level. So finally, she was extended up to C5, which is where the story ends, thankfully. So I'd like to thank you for your attention and hope to have some contributions.
Thank you, Marcus, for an excellent, informative talk with the excellent review of the literature. It was really impressive. As for your last case, I hope you don't end up fusing that with an OC fusion.
So that to a teeth.
You're on the way for that at some point. So we'll be receiving now questions from the attendees. You can either type your question down in the chat box. Just make sure that you mark your question, mark to everyone, so everyone can see your question. The other option will be to raise your hand and unmute yourself and go ahead and ask your question. I actually have a question for you, Marcus. You pretty sure you came across multiple papers by the WashU group, especially when Linky was part of the WashU group, as well as papers from the University of Utah with Mike Dobbs and Daryl Brodsky, who had the largest cohorts for PGK cases in the literature. You mentioned that stopping at the lower thoracic level is a risk for PGK, and you highlighted that very well. And that's what they mentioned as well. What's interesting is that they found out that there is no difference whether you stop at T9, T10, T11, or T12. So what we usually use to understand is T10 is probably the first safe level which you can stop at, is basically not different from T11 or T12. And the other thing is they found out that the rate of revision when you go to the upper thoracic spine is equivalent to the revision if you go to the lower thoracic spine, but for a which was pseudoarthrosis when you go to the upper thoracic. So I personally would prefer having pseudoarthrosis over PGK at any day, but I wanted to know your thoughts on that as well.
Certainly, yeah. Obviously they have a very big series, which I'm not sure if they're very proud of it, but someone's got to have the biggest series somewhere. And they've done a huge amount of very valuable research. And yes, they did show an increased mechanical failure rate lower down in the thoracic spine and a higher pseudoarthrosis rate when you got up towards the upper thoracic. And certainly I think everyone would prefer to have a mechanical stability and a biological failure at the upper levels, because you can go back and you can inject, or you can put BMPs, you can put in stem cells if you're into that sort of thing, and you don't have all of the stresses of trying to salvage and correct the sagittal alignment. If your sagittal alignment is correct from the first go, and it's purely a matter of having a pseudoarthrosis, in a lot of these patients, you can completely leave it if it's a pain-free pseudoarthrosis in the first place. If it's painful, you can either add on by doing posterior augmentation with the BMPs and things, depending on what level you're at and what expertise you have. You can go and do anterior surgery. You know, you can do minimally invasive anterior interbody cages via a far lateral approach up to T78 quite easily, with you know, just a little 3 centimeter, 4 centimeter incision, but you do have to remove more rib. You have to remove about 10 centimeters of rib to get in. But that's certainly a preferable situation to actually having a PJK further down, because then you extend further up and you still run the risk of developing pseudoarthrosis. So no, I think probably people are more likely to extend more proximally and try and augment try and make sure you get a decent fusion mass up in the upper thoracic spine. Is the way that people are going.
Would you like to go ahead and
thank you, Dr. Marcus. This was really, really informative and really up-to-date information from the literature. I have a question from Dr. Naif. He's asking about the role of post-operative brace, or TLSO, sorry.
Yes, there isn't much in the literature on it, but the group in the UK where I trained that had the best outcomes for all of the degenerative, the ASDs, braced people for 6 months post-operatively, and that was an over-the-shoulder brace, so it was high. I mean, they didn't normally do a CTLSO, but it would certainly be a very high thoracic, and for 6 months for everybody. There was no you know, if you didn't have osteoporosis, they didn't say, well, that's fine. They braced everybody, but most other places don't, and you know, their results would show that it's probably a beneficial thing to do. The biggest problem in the Middle East is tolerating a brace is very difficult because of the heat, and the same in idiopathic scoliosis in adolescents. The reason braces don't work very well is because no one wears them, because they're just intolerable things to suffer. But yes, they would be a very good idea, as long as they get proximal to the fixation.
Okay.
It's the most important.
We have
Otherwise,
another. We have another question here. Are polyester bands better than hooks to prevent the
well, they came out. Well, difficult to judge really. They're both. You could probably use both. Is one of the trials actually used TP hooks for a few levels and used spinous process bands. Obviously, it's a bit more difficult to use the sublaminar weave things if you've got the TP hooks as well, because you're fighting for space in the thoracic vertebra. But there are people starting to try and use both, and with the vertebroplasty as well, to try and, you know, in the very high risk people. I recently had a lady who had a T-score of -4.5 after 2 years of teriparatide. And there's nothing more that we can do for her osteoporosis, and she's chin on chest. And the plan for her will be to use 3 levels of hooks and the bands and cementing all the screws, all the HA-coated screws, to put absolutely everything in to try and hope that we only have to go there once.
Yes, Dr. Marcus, there's another question about the use of role of more of transitional dynamic rods.
Yes, they what's called the topping off, the kind of soft landing sorts of things. The literature, there aren't that many reports of them. The idea is that they work like the TP hooks, in that you're trying to reduce the stresses over the UIV, obviously not UIV +1 because you're not going into it, but you're still putting the pedicle screws in, and so the stresses are higher than using a TP hook or using any of the bands. So they have a slightly higher failure rate than the TP hooks, or even going to the ribs. That's the other option you can do, is to use a sort of vector technique and actually go onto the ribs themselves on a bit further laterally. So I don't have a lot of experience of using them. I did try them, oh gosh, about 8 years ago. But we had a few of them, the actual them break, because where the topping off bit from the solid bit to the flexible bit actually fatigued and fractured. So I don't have a lot of experience.
I think the problem with the PGK is the best evidence that we have in the literature is basically a level 3 evidence. We don't have any solid evidence regarding any of the different techniques that can really help you with PGK. So we tend to try different things. Some of them work, some of them don't. We like them, we hate them, then we move to other methods. The problem is we don't have really a solid evidence in the literature so far that can support any of the proposed tricks that can help you get away with PGK. I have a question actually from Alaa Zakout from the GCC Council. Alaa, you can go ahead and unmute yourself and ask your question.
Hello, everybody. Thank you, Dr. Marcus, for your good lecture. Actually, I want to put some advices, or I mean, some tips and tricks in avoiding the PGK. Usually, in the after, of course, planning the surgery, and we are decided which level we are going to stop. In the upper surgical site, actually, we should preserve the supraspinatus and infraspinatus ligaments as possible for the upper 1 or 2 levels. So this is another thing to avoid to make it more stable. The other thing is to try to make the kyphosis between the upper 2 screws. So at the upper screw, we should put some distraction between the upper 2 screws, especially in scoliosis surgery, or if we want to extend our previous failed surgery. At the upper levels, we'll do distraction, not compression. So we are inducing kyphosis between our upper instrument levels. So, I mean, if you are doing this by distracting and not doing compression and preserving the interspinous and supraspinous ligaments, you are giving good things. And also try to make a kyphosis in the road at the upper levels. So you are putting the kyphosis just distal to the uninstrumented vertebra. And this is my things that will help in reducing the risk of proximal junction kyphosis. And thank you.
Shukran. Yes, absolutely. One of the big things is contouring the rods well and trying not to damage the ligaments and the facet capsules. But if you're instrumenting the levels, it's very difficult not to affect the facet capsules. That's where the TP hooks or the rib constructs come in very well, because you can leave the facet capsules alone. But certainly you should try and not strip off. And if you do MIS for the top few levels as well, you try not to strip the muscles off. Because obviously if you're doing a midline strip, it's different if you're doing a Wiltshire approach and you're trying to keep the multifidus and longissimus or multifidus there. But certainly trying to make sure you get a bit of... the problem with putting kyphosis at the proximal end is it depends a bit where you're stopping and which of the Wosely classification spines you're in. If you're still in a lordotic segment, you don't want to try and kyphose it too much. But otherwise, generally, yes, I certainly try and get some kyphosis at the proximal end. And make sure your screws are very good and try and make sure they're not anatomically lined up. You want to try and get them straightforward as much as possible as well.
Yes. Dr. Marcus, there is a question from Dr. Amin Hanina. I think it's a comment rather than a question. The real issue of the BGK will not lead to more anterior procedures.
So can you repeat it again? Sorry.
The real issue of the BGK, it will lead to more anterior procedures. Do you think that?
Generally, no. Usually these patients have got significant morbidities, so people are trying to avoid doing too much anterior surgery on them, particularly going through the chest, just because of the morbidity with it. Yes, minimally invasive does make it better, but it's very difficult to reduce a PJK from anteriorly, first of all. Most of these PJKs have osteoporosis, so anything that you do at the level, if you put an interbody cage, unless it's a big cage, you still run the risk of it subsiding. So I think it's something that you have that you can use if you need to, and using anterior plates as well is certainly an option for salvage. Most people aren't using it as a primary procedure, just to try and reduce morbidity initially.
So Marcus, you talked about never to correct the lumbar lordosis more than 30 degrees, especially if you're dealing with old populations or osteoporotic. Now, I know you do a lot of OLIF surgeries, anterior psoas approach. So do you still, and most of the population of the patients that we have over here in the GCC region are patients who are above 55 years of age, falling on that category that's high risk already. So do you still go for the hyperlordotic cages when you go for OLIFs, especially that now they have up to 18 degrees of a cage? So what are your thoughts on that?
Yes, I do use the hyperlordotic cages. I may not use the 18s necessarily, but the most important bit is to try and recreate that 40 degrees of lumbar lordosis, or the 2/3 of it, the lumbar lordosis in those bottom two levels. Because if you don't correct those, you're not going to correct the SVA. And if the SVA is not corrected, then you're going to run the risk of failure anyway. So what you should try and do is, as I was saying, is try and put it back to the ideal position. That's not fully corrected. Certainly correcting the lumbar lordosis more than 30 degrees is a significant risk factor for creating PJK. But most people don't need more than 30 degrees. Well, certainly you hope not. But if they do, then either you stay short, you just do L4 to S1 if you can, and then you've got at least plenty of space if you start to run into trouble. Because if you've just got someone who's got the bottom L4-5 and 5-1 disease. You don't want to be going up to T1 to just try and prevent a PJK. That's where the extremes of surgery come in. So I think the OLIF is very good because you get a good correction. It's possibly not quite as good as an ALIF. You're not taking off the whole of the ALL, but you're still getting a decent sized cage. The ALIF, of course, gives you the biggest cage. But of course you need vascular access surgery for that, particularly 4-5. But that's the most reliable way to try and correct. And if you do it from anterior for that, and your posterior screws are not in tension, then hopefully you, with a decent sized cage, you won't run into subsidence and failure. But there, kind of topping off things is another option. You're putting in either the soft ending with the flexible rods or TP hooks, or even putting some of the tethers in.
Right. I think it's very important as well to understand the difference or to notice in your patients when you have a flexible versus a rigid thoracic kyphosis when you're pre-op evaluating those, because really, I fell in that trap like a couple of times, and it wasn't really a great outcome when it comes to PJK post-operatively. So standing x-rays are always a must. They usually look different on their standing x-rays, not just for the height of the disc, not just for the kyphosis, but they really tend to go into kyphosis when they stand more than when they're lying on the bed. I think we have a question from Dr. Omar Al-Nouri.
Yes, it's a question at raising hand also.
Oh, right. Go ahead and unmute.
Hello, thank you, Dr. Marcos, for your very informative lecture. Actually, I asked a question which I typed it, and I have another question. What's your threshold to treat the BGK? Is every BGK it's need to be treated? And when you have to treat it, or when you have to like interfere before worse happen? And there's another question for you. Maybe it's written. Is stopping like at T9 or T10 will make like stopping at T9? It will make it like lesser chance for BGK to happen, or it's the same? Do you have?
I'll answer that one first. The T9, T10 one increases the risk, unfortunately. The finite element thing showed there's up to a 60 times increase in the compressive force at the UAV and UAV +1 if you stop at T9 or T10 as opposed to T1. So it does increase the risk. For PJKs, only if they're symptomatic do you even entertain the idea of having to do something. If someone's asymptomatic, then that's the PJK. It's the PJFs, the failure ones, that you have to intervene in. And if you follow the ISSG, the table from 2017, once your score gets to 7, if you tot it up on there, then that's when you're thinking about intervening. And if you go, I could go back to it, but it's based on neurological deficit, can score you up to 4 points. Pain of VAS of more than 5 will get you 3 points. Those two together are the 7 that you need. So it's quite easy to get up to 7 to know that you need to revise it. But a lot of it depends on the patient and their comorbidities and likelihood of actually benefiting from the surgery, as it is major surgery in becoming less fit people. So generally I would duly observe a PJK, and I'd need my arm twisting to start revising the PJFs unless they start developing deficits.
So Marcus, I think what you just said, if you review, Omar, the series by Washu, by Licky and his colleagues, you'll find in 2013 that they published that their incidence of PJK was around 24% in all the cases that they operated. And then in 2015, they published again that the incidence of PJK went up to 32%. Now they reoperated on 25% of those, with the major cause of reoperation was myelopathy. That's just adding to what you said, Marcus. Dr. Saad, would you like to go with the next question?
Yes. We have a question from Dr. Spiggy. For osteoporotic patient, not urgent, do you use brace and try to increase body mass BMD by Forit or Prolia? Use hydroxyapatite coated screws, perforated vertebroplasty, etc. What's your choice?
Absolutely. If I can get away with not operating for 6 months, teriparatide has a chance to increase their bone mass, then yes, I would do that. In the meantime, keep them in a brace to try and keep them functional. And just, assuming that you've managed to do that, then unfortunately they're still likely to be osteoporotic to a significant degree. And so, yes, I would use all the precautionary things I could do. So I do vertebroplasty for the upper instrumented level and the one above that with the HA screws or cement screws, depending what's available. Yes, the cement screws can be quite difficult in the upper thoracic spine because you have to have at least 4.5 millimeter diameter screws to get cement down, and some of the high thoracic pedicles can be supported in that. So you don't really have a good option. So for them, the HA coated screws may be better. But yes, you do absolutely everything that you can. Tell them to eat cheese as well. They're very difficult patients, unfortunately. So my lady with the T-score of -4.5 has had almost total colectomy for abdominal problems, and that's 2 years of teriparatide. She went on to denosumab, and her T-score deteriorated to -6, and she's gone back onto teriparatide, even though you're only allowed to have it for 2 years for increased malignancy risk. But her bone density was getting so bad, we didn't have a choice. And at -4.5, I operated, and I did cement screws, and I did vertebroplasty, and I got a UIV failure. She collapsed down and had to extend up to C5. It was T1 that collapsed.
Can I ask a question?
Certainly.
Sameh, if you might, I want to ask a question. You have a BGK patient, same as Dr. Spiggy said, and you have to operate that upper segment. Would you choose to do it as MIS, transcutaneous screws, or would you do it as a hooks in the upper segmented area?
I would prefer the hooks, TP hooks, rather than sublaminar hooks.
Okay.
Mainly because they show the reduced stress on the upper instrumented vertebra. And with the TP hooks, you can then still use a tape. And I mean, you can't do hooks minimally invasively, unfortunately. That's
sure.
the main problem with them. So you are going to have to open, you can put the MIS screws further down. There's a lot of argument over whether people actually get decent fusion masses with minimally invasive surgery, because you're not just sticking a screw into a hole and putting a rod on. That's not fusing someone, that's stabilizing. You actually have to do some decortication, get some grafting to try and actually get a fusion mass. We know with a lot of these patients that metal fatigues and it fails. And if you don't get a fusion mass, you're going to run the risk of your implant failing, and that's when you're going to suffer other problems. So trying to get a decent fusion mass is critically important to all of these.
All right. Do you do a DEXA scan for all your patients preoperatively?
Yes.
Okay.
Simple, yes.
And one more question that I have for you, actually, regarding rods. All right. So most of the time, I feel that I prefer using cobalt chrome rods for deformity surgeries, but most of the time, I feel that they are super rigid for such old osteoporotic patients. So my question is, cobalt chrome versus titanium versus stainless steel rods, which ones are one to go?
The argument on this is very much on contouring. If you can contour your rod perfectly, then you could use cobalt chrome. But what you can't do with a cobalt chrome rod is not have a perfect alignment and then use a reducer, an encourager to pull the spine to the rod, because either the screw will pull straight out in the first place, or it will pull out sometime after you've put it together. So I use titanium, I must admit. stiffness of it, Young's modulus is less than cobalt chrome. Cobalt chrome is the stiffest of all the rods, and then stainless steel. But generally, the rods don't bend too badly. The contouring is better, and it's a bit easier to use for the titanium. And the Young's modulus is a little bit closer to bone. So generally, I use titanium, I must admit. A few instances in some deformities where you've got to hold it quite rigidly and you use stainless steel. But then if you're having to do that, you know that you're running the risk of it cutting out.
Right.
So, last question from our colleague, Dr. Khalid Faraj. What is the incidence rate of BJ kyphoscoliosis in the thoracolumbar reconstructive surgery? And what are the tricks for preoperative prevention and postoperative treatment?
So thoracolumbar junction, I mean, anterior surgery wise, you can do far lateral kind of, the X-lift type things, D-lift, you can do to get to thoracolumbar junction. You can get there. Some particularly skilled practitioners can do it via an O-lift as well. You can get to T12L1 by releasing the crust of the left crust of the diaphragm and to get cages in from O-lift cages. So you've got some options for thoracolumbar junction. The pedicles T11 and T12 are almost directly straight on, so the pull-out strength for them is quite weak. So generally, that's why people don't stop at them, because normally you want a nice divergent screw pattern, but it's difficult to do at T12 and L1, just because of the orientation of the pedicles. And so, what was the first part of the question?
How to prevent and prevent it preoperatively, and how to treat it postoperatively?
Well, the prevention preoperative is all of these things. So it's making sure that your surgical planning is as good as you can. So you've got all of your surgical parameters. You use whatever program you use so that it can tell you what your ideal correction is going to be, particularly if you're doing osteotomies. Something like a PCO or a vertebral column resection, you really got to have a good idea of how much bone you're trying to resect. And also, if you've got a coronal deformity and you're doing an asymmetric PSO, it becomes very complicated. And that's where a computer model can be very helpful. It can tell you on the right side you need to remove 1.2 centimeters of the pedicle and the vertebral body, on the left side only 0.6. And so you can kind of try and tailor your osteotomy accordingly to try and get your correction. Because you want your primary correction to be there without relying on the implants to do the correction for you. You run the risk of non-unions through PSOs and vertebral column resections anyway. And then surgically, double rods on both sides, because there's a very high incidence of rod failure when you've done osteotomies. So you have to have double rods to protect all of it. But the biggest thing is trying to get your sagittal profile correct for their age, so their ideal Russelli correction, which means that you can allow a slightly increased SVA as the patient is a bit older. Because if you overcorrect it, or if you put it back to where it should be, you're overcorrecting, and that's more likely to cause a failure.
Right. Feeds your ego as a spine surgeon, but it doesn't matter your surgeon, your patient actually. Dr. Faraj actually has another question. Do you do decompression for all your PGK revisions?
Well, it would depend on the imaging, I think, but generally, yes, I would think that. I'm just trying to think of the last ones. I mean, certainly the case that I showed where you could see there was quite significant spinal stenosis, you need to be quite careful with your reduction. It's a bit like a spondylolisthesis reduction. You can cause neurological injury if you just reduce without decompressing first. So generally at that level, yes, it's against your better judgments and what you prefer to do a laminectomy at a level where you're trying to preserve the posterior elements. But sometimes you have to physically decompress and know that when you are actually reducing, that you're not going to cause a spinal injury, paraparesis. Yes, it's not nice. And sometimes the patient will, you can test them, you can lie them prone on the couch in your room, check that they're neurologically remain intact, because that's the position you're going to put them on the table. you can be a little bit more confident. I mean, you're going to be using neuromonitoring anyway, so you need SSAPs and MEPs, and you position them on the table. And if it's reduced itself, which a reasonable number will do, then you can just, and your neuromonitoring will be fine, you can just fix. But if you're in any doubt, then decompression is obligatory if you've got any concerns, or if your spinal cord monitoring goes in any way abnormal.
Cortical trajectory screws versus regular pedicle screws. Any thoughts, Marcus?
By the cortical ones, I think it's sort of midlift type ones, or
right.
They're fine. You can only do them in the lumbar spine, of course. You can't do them further up, and they've got a stronger pull-out strength. So, I mean, I generally do use the normal standard screws. It's what I've trained with, what I'm used to doing, what I'm familiar with, and the majority of the time that's fine. I think the cortical trajectory ones and things are good for revisions when you've had to remove a screw, particularly for loosening, where you've got a very wide hole, and you either have to put an 8 or a 9 screw in. Then if you can go in a different direction into virgin territory, you get a much better hold. So I wouldn't do them in primary, but I would for revision.
Excellent. Prasad, do you have anything to add?
Yes, another question. Could be MIS as over the top unilateral laminotomy, bilateral decompression be helpful in decompression?
I mean, it can be, yes. Certainly, kind of endoscopically, you can leave most of the tissue. I mean, it depends what you mean by MIS, of course. If you're talking a tubular thing, then it's not as minimally invasive as an endoscopic one. But if you're trying to preserve as much soft tissue attachment as you can, then certainly a minimally invasive approach for decompression and putting the screws in is good. You can decorticate using tubular retractors and things, so you can actually prepare. You can make a slightly bigger hole than just a purely percutaneous procedure, and start your entry point, and then decorticate, and then put the screw in afterwards. You've got yourself a fusion bed, and that's something that I have done before. Yes, I'm a fan of MIS.
Sameh, waiting for your resolution. What happened to your case?
Well, we haven't yet operated that case. Still pending. We're in the process of surgical planning now for that case. Actually, I hope we don't end up going all the way up the way you did, Marcus, with your case. So I don't see any further questions here. So just would like to remind you guys of the activities that we have over the coming couple of weeks. So we have an AO-Spine combined Middle East webinar that would be about C1, C2 pathologies that would be chaired by Dr. Saad Hamdan and Dr. Muhammad Khattab on May 1st. Then on May 8th, we have another combined Middle East webinar that's going to talk about different surgical options for cervical degenerative disc disease. That will be on May 8th. Then third GCC webinar that's going to talk about dural tears. And that would be by Omar Nouri and Dr. Muhammad Khattab. Last but not least, I'd like to thank our faculty, our presenter, Dr. Head. Thank you very much for your presentation. That was really valuable and informative. I can see a lot of comments that really love the presentation. A lot of people are actually asking for the presentation. But thank you very much. I really appreciate it. And I'd like to thank my co-moderator today, Dr. Saad Hamdan. It was a pleasure having you on board today.
Thank you. And thank you, Dr. Marcus. It was really, really brilliant.
Shukran. Hope everyone stays safe.
Thank you. So we wouldn't take much of your time, guys. You can go back to your prayers, your work, or binge watching Netflix, or whatever you're used to on those days. So till we meet again, stay safe, and thank you, everyone.
Thank you.